Hello, everyone, and welcome to today's Compassion in Action webinar, Managing Traumatic Stress, Evidence-Based Guidance for Organizational Leaders. I'm Stephanie Adler-Yuan, Director of Education and Training here at the Schwartz Center for Compassionate Healthcare, and I'll be your moderator for today's session. We're so grateful that you were able to take the time out to join us today. The Compassion in Action webinar series is a program of the Schwartz Center for Compassionate Healthcare. We're a Boston-based nonprofit organization established 25 years ago in 1995. Many of you are probably familiar, I think, with our flagship program, the Schwartz Rounds, which is offered in hundreds of our member organizations around the world and provides caregivers from all healthcare professions with a forum for discussing the complex emotional experiences of caregiving. So let's get started. Before we do, there are a few things we'd like to note about today's session. First of all, the Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Our program will last 60 minutes today, so we're going to have a presentation from our speaker for about the first 45 minutes, and that'll be followed by a question and answer session. And although all of our attendees are participating in listen-only mode, we do encourage you to interact with our speaker using the questions pane on your GoToWebinar dashboard. The other thing to note is that this is a computer audio only webinar, so there is no dial-in for this presentation. I'd also like to add that we know so many of our colleagues are unable to join us here today as they are tied up elsewhere. And so the program will absolutely be recorded and posted on our website as soon as possible, which will be by about noon tomorrow Eastern time. So that'll be posted for future viewing, and we'll also be posting a PDF of the presentation slides and an additional article as a resource for you all. Last but not least, as you exit the webinar, we will have a very brief survey that we'd love for you to take a minute to fill out so we can capture your assessment of the program. We absolutely read every comment, so please take a minute to fill that out. And now, it is my absolute pleasure to introduce my colleague and our host for today's session. Dr. Beth Lown is Chief Medical Officer here at the Schwartz Center, and she's Associate Professor of Medicine at Harvard Medical School. Welcome, Beth.
Thank you so much, Stephanie. Good afternoon. Thank you all of us for joining us today for our Compassion in Action webinar series. I'm very, very pleased to be able to introduce our speaker, Professor Neil Greenberg. And I have to say, I've been reading all of his articles very closely. There's been many, many wonderful articles on managing mental health challenges faced by healthcare workers during the current pandemic and other topics. We'll be posting one of his articles on our website archive. Professor Neil Greenberg is a consultant academic, an occupational psychiatrist at King's College in London. Neil served in the United Kingdom Armed Forces for more than 23 years and has deployed to a number of hostile environments, including Afghanistan and Iraq. He is really widely published, more than 250 papers and chapters to his name, and has been much celebrated as well. He was shortlisted for the Royal College of Psychiatrists Psychiatrist of the Year in 2015, and he was awarded the Royal College of Psychiatrists Presidential Medal in 2017. He also runs an organization called March on Stress, which offers some of the trauma-related training that he'll be talking about today. We're just thrilled to have him here with us all the way from London. Welcome, Professor Greenberg.
Thank you very much indeed. It's a real pleasure to be here. Early evening for me, and I believe early afternoon for you. So very kindly, Beth introduced me. I work as a psychiatrist and also academic. And I'm particularly interested in how organizations respond to challenging environments, in particular trauma. And within the Royal College of Psychiatrists, I chair an occupational psychiatry special interest group. And I'm lucky enough to work with a number of fabulous organizations, helping them develop preventative strategies in order to try and protect their staff. Just at the moment, during the current pandemic, I'm working at a hospital in London called the Nightingale Hospital, which has been specifically set up to provide care to patients during the current crisis. And we're trying our best to develop a evidence-based staff support plan. So it's been really quite exciting to put all the research that has happened over the years into practice to try and make sure that healthcare professionals' mental health is as protected as it can be. So this is my kind of overall plan for today, for my talk, and I'll sort of run through those topics and hopefully leave you with a few good takeaways. If you are interested in more specific information and references and the like, then I know you'll get the slides, and on there are some of the websites that you can freely download. I think all the academic papers that we've produced from there. And my main academic base is King's College London, and I work both there with the King's Center for Military Health Research, obviously carrying out research on veterans and military personnel, but also with the Health Protection Research Unit, which actually was set up in order to try and mitigate the impact of trauma on organizations. And so particularly at the moment, obviously we're pretty busy. So the first question really is, what is traumatic stress? And this, as you may or may not know, comes from the Diagnostic and Statistical Manual, Volume 5, which came out in 2013, published by the American Psychiatric Association. And I've just underlined a couple of points there that I think are relevant to organizations. So the first is that I've underlined the word threatened. And whilst the media makes lots of noise about real traumas, things that actually happen, the fact is, from an individual's point of view, if they strongly and absolutely believe that something could have happened, then that too can be traumatic. So in terms of organizations and trauma, where you have a near miss or where a serious untoward incident happens but doesn't thankfully lead to patient harm, then actually we should also think about the mental health of people involved in those incidents, not just the ones where unfortunately something really bad does happen. Also, as you can see along the bottom there, from 2013 onwards, when this was published, we now recognize that actually, as well as the type 1 trauma, that's the big event, the death, the terrorist incident, the explosion, the dog bite, the assault and the like, we know that many professions, and healthcare workers are a very good example of this, can be repeatedly exposed to traumatic events. And so they have an accumulation of what's called type 2 trauma. And we know that that too can also cause post-traumatic stress disorder. It's not just the single big event. And importantly about type 2 trauma is that it tends to have a very insidious onset. And so actually people affected by type 2 trauma often have a very large dose of it by the time that they actually seek any help. And it kind of creeps up on them. And that's important because if we don't nip it in the bud early and spot type 2 trauma before it has a really big impact on people, then actually it makes it really quite difficult to treat such people in a way that would get them back to work. So if this is most of us, and most of us kind of go along through life at about 70%, there's a few energizer bunnies out there who seem to get up to sort of 90%. And a few what you might call bottom feeders, who seem to get away, not doing very much at all. Good jobs if you can find them. So imagine someone who's at work and they're normally an easygoing, kind of quite effective individual, and then something really bad happens and they come in the next day, they smell of alcohol, they're a bit shouty, and they're really not able to concentrate. That's kind of the type 1 trauma. Doesn't always have an impact straight away. But most of us know when we've been exposed to a particularly big event. The real challenge, though, is on what the type 2 traumas, where actually the impact is slow and over time. And then as someone's going downhill, then often when someone says to them, so how are you doing? The answer tends to be, I'm fine. And of course, fine doesn't actually mean you are fine. It's not really a mental health check at all. And then something small happens, a relatively minor incident, and the person who's been saying they're fine for the last 6 months then finds that they're unable to cope with that. And everyone's really surprised because they can't understand why they can't cope, because some months beforehand that person really was okay. But of course they've been going downhill for a while now and no one's actually spotted it. So that's the type 2 trauma. And And our data from looking at, we did a study looking at the impact of working with children who've been sexually abused, and that included police officers, social workers, and also healthcare workers. And although when you put all that data together, it wasn't fabulously useful in terms of diagnosis, the studies were pretty conclusive that over 50% of people in those groups suffered with significant distress that was likely to affect their ability to work. So that's a very significant amount of people who've been exposed to repeated accumulated type 2 trauma in the course of their work. And of course, then there's PTSD. For diagnosis of PTSD, we know that you have to experience a potentially traumatic event. And in the past, we used to think that actually that event had to cause helplessness, horror, or fear. So if you imagine the firefighter going into a building to rescue people, then actually if they weren't helpless, they weren't horrified or fearful, the belief was that they weren't going to then develop any mental health problems. Over years, we've come to realize that that's not true, and that actually you can perform perfectly well at work and do an amazing job. And then as you come home and begin to reflect on what you've done, it's only then that you begin to suffer with symptoms. And for a diagnosis of post-traumatic stress disorder, you need to have these 4 sets of symptoms for more than a month. So intrusion symptoms are you can't stop thinking about it, you may dream about it, you may get triggered when you see something that reminds you of the trauma. You avoid the trauma, so you don't want to talk about it or go near things that remind you of it. It changes the way that you think about the world. And importantly, therefore, it distorts your perceptions. So when you look back at what happened, you don't have a truthful view of the event itself. You have a distorted view, often blaming yourself or other people in a way that just is not fit at all with reality. And it changes also that your sleep and your concentration. It makes you more jumpy and angry and risk-taking. Now, importantly, in order to suffer with PTSD, your symptoms have to be functionally significant. So they have to have an impact on your ability to function. This is important because many people suffer with some symptoms after a traumatic event, but they don't have post-traumatic stress disorder. So this is a slide after a single type 1 trauma. And this actually is a group of people who were subject to armed robbery who worked in a bank. What you can see from this slide is along the bottom, you've got the number of weeks that after the event happened. And on this y-axis, you've got the percentage of people who have a lot of trauma symptoms. Now, importantly, what you can see is straight away after a traumatic event, about 60% of people have lots of symptoms. But that also means, of course, that 40% don't. So after a major trauma, it perhaps might be a bit surprising, but sometimes people's first thought is not, that was terrible and I'm scared and horrified. It might be, I wonder what's for dinner, or these shoes are a bit tight. Not everybody goes on to experience a strong stress reaction. But you can see here that quite a lot do, and that over time, most of those people tend to recover without the need for any professional intervention. And in this case, you're left with about 10% of people who have a persistent disorder. Now, this is important because what tends to happen in the first few days after a traumatic instance is people tend to throw a lot of resources at distressed people. So that might include counselors or psychotherapists or psychological debriefers. And then what seems to happen, as you can see, is that a lot of people get better. And they don't get better because of those crisis counselors or debriefers or the like. They get better because that's what happens to people anyway. And so the important thing to recognize in this study, which is what's called a naturalistic study, that means that people weren't interfered with whilst they were recovering, is that lots of people become distressed. That's quite normal. Most people who experience distress experience recovery over a period of weeks. But unfortunately, you're left with a group of people, in this case 10%, the actual figure varies, who have a persistent disorder. And in most cases, that doesn't tend to get better over time. And these are the people here who need professional intervention. People who are in the first few weeks after trauma, professional intervention needs to be kept away from them, as we'll probably discuss later. Now, it's important to say that although I've spoken about post-traumatic stress disorder, that is not the only mental health problem related to trauma. We know that many people who go through trauma don't get PTSD, but they suffer with depression, anxiety, what are called adjustment disorders, and also substance misuse. So they may drink too much alcohol or they may misuse illicit substances. And in the UK, our National Institute for Health and Care Excellence, which is our national body which looks at treatments that work in order to provide guidance to the health service, rather than worrying whether someone may have PTSD or not, whether they just meet diagnostic criteria or just fail to, they use the term of clinically important post-traumatic stress symptoms. And that's important because if you're seeing someone after a traumatic event, they're functionally impaired and they've got lots of symptoms, you don't need to worry whether they've actually got PTSD or not. If they're trauma-related problems and they're having trouble related to an incident, you should get on and provide them with appropriate care or support. And in terms of an organization, the three broad strategies that are useful to think about are: how do you prevent people having problems, often known as primary prevention? How do you detect people who have early problems before they become unwell, often known as secondary prevention? And then for people who have developed formal mental health disorders, how do you get on and actually provide them with treatment that may have a good chance of getting them back to be able to work again? And the UK Psychological Trauma Society has produced a guidance document on this. You can see the website link there. Now, the first thing to say about preventing people becoming unwell is that every organisation, particularly ones that routinely expose staff to traumatic events, should have considered this. And they should have a operational stress policy or traumatic stress policy that integrates very well with the people policy or the human resource policy or any other stress management policy. It shouldn't sit by itself. It should be part of what an organization does. And that really will help describe what the philosophy of the organization is. And the phrase you can see there, which I like, is that people have to know you care before they care what you know. And it's all very good having great policies that sound nice, but actually if those policies don't follow with behaviors and actions that actually make difference to people's lives, then they don't make any difference and people won't believe them and they won't follow them. Now, in terms of people who are working in safety critical roles, and of course many healthcare professionals are working in safety critical roles, there is this interesting interplay between the individual's duty, if you have a mental health problem, you need to tell someone, and of course the management's duty, which is that if we're exposing you to traumatic situations, then we need to make sure that we put in place sufficient mitigation measures. And in safety critical roles, when it goes wrong, then of course in healthcare settings, patients unfortunately get injured or killed. And if it were to be a pilot or a train driver, then of course many people's lives could be lost if people are suffering with mental health difficulties, which impairs their function. The next thing we should think about is about how you build supportive teams and ensure that junior leaders, what I call supervisory level leaders, really know what they're doing in terms of mental health. So this is data from British troops who were in Iraq in 2009. And whilst they were out there, myself and some colleagues went out and we carried out mental health surveys of deployed troops. And we looked at lots of things. And this particular slide is looking about unit cohesion, so team camaraderie. How well do people get on with each other within a team? This scale here is called the post-traumatic stress disorder checklist. And in broad terms, the higher up the scale you go, the more mental health difficulties you've got related to trauma. And what you can see here is probably what you know anyway, is that if you're in a good team, which is described by these different individual items here, then actually if you're in a good team, you're less likely to have traumatic stress symptoms than if you're in a poor team. And that won't surprise most people. We know that being in a team is a good thing as long as they're supportive. We'll come to social support a bit more later on. However, in terms of bang for your buck, which obviously is a phrase that I'm sure has more resonance in the US than it does over here in the UK, the really important people to understand about mental health and to know how to have a psychologically supportive conversation are people in supervisory positions. And so this slide is looking at British troops who were in Afghanistan in 2010. And you can see here we measured leadership as, look at these four phrases. So a good leader doesn't embarrass unit members in front of others. They don't accept extra duties in order to make themselves look good, to impress their seniors. They treat all members of the unit fairly, and they show concern about the safety of unit members. Now, overall here, we found that British troops, is about 1,500 troops in this sample in 2010, about just under 3% of them probably had post-traumatic stress disorder. But what you can see here is a 10-fold difference in the rates of probable PTSD between troops who felt that their immediate leader was a good leader or a poor leader. Now, this is really interesting because what this said to us from a military point of view is it wasn't all about the trauma itself. It wasn't how many people are being injured or killed. It was really about the quality of a good leader to be able to talk to their staff members. And importantly, the quality of a good leader to encourage staff members who have got difficulties to get professional help. So the biggest impact on mental health, particularly in organizations, is people who are at a very junior level, often, unfortunately, ones that tend to not get management or leadership training, but whose influence is really very important. Now, as well as leaders who are important, so is being able to do your job well. And what we've showed in military studies, if you look at deployments of troops, and actually troops who were deployed to do a job in somewhere challenging that they weren't really trained for, actually were far more likely to have mental health difficulties. Certainly in my current role in the COVID-19 outbreak, what we're doing, unfortunately, in the UK is having to use healthcare workers to work in intensive care units who have never worked in intensive care before. And whilst they're given some quick training, we know from this data that they are going to be vulnerable to suffer with mental health problems because they're going to feel that they're not fully able to do the role that they have been asked to do. And the other thing that we look about is also about the impact of what we call psychoeducation or mental health training. And many organizations quite rightly try and prepare their healthcare staff to face traumatic experiences and morally injurious experiences, such as the ones they're facing currently. But the question is, how useful is it? Well, when we've looked at this in a number of settings, first of all, we find that unfortunately, it does seem to help when people are doing their job. So we looked at troops who were about to deploy to a war zone, and we found that troops who had mental health training beforehand did tend to do better on the job. However, there was no impact in terms of a long-term health. By that, I mean that although it seemed to help by doing the job, it didn't prevent people from getting PTSD or depression. And that's probably because there are so many other factors that are important in working out who gets mental health problems and who doesn't. It may, however, be an important part of helping to shift organizational culture over time. And what we've done is to measure within the British military the rates of mental health stigma, and we've been measuring them since 2009. And we have seen a consistent decrease in stigma over the years. Stigma has not gone away, but we're pretty sure that all the mental health interventions and mental health training that's gone on in the military has had an important impact upon it. But just going back to those supervisors once again, really good study which was done in Australia, in New South Wales, in firefighters. And what they did there is they prepared a 4-hour training intervention, training up fire station managers, so the people in charge of the fire crews, how to have a psychologically savvy conversation in order to try and encourage their staff members who might have gone through difficult things to talk about their mental health problems. And the way they did this study was it was a randomized controlled study. So that's a really high quality study. It was published in a journal called Lancet Psychiatry, which is a very good journal to get your publications in. And what they did is to look at the sickness absence in people in the teams who had the mental health training for managers and the sickness absence in the teams who didn't. And they compared the 6 months before the training with the 6 months afterwards. And what they found is that for every pound invested in that training, they saved £10 on sickness absence. So there was a really clear impact of that training for managers in protecting staff's mental health and keeping them at work, which is really important. And the most useful bit of the training seemed to be giving the junior managers the confidence to have one of those chats with a member of staff who might have been through traumatic experiences, which they didn't have before the training. What about screening? Now, many nations routinely use psychological health screening in order to protect their military forces, and the US is indeed one of those organizations. Now, you can use screening a number of ways. So you can screen people before they join an organization or before they go into a particular role. In a healthcare setting, that might be before you go into perhaps join an intensive care team or an emergency department team. And what the aim of the screening is to detect people who might be vulnerable to suffer with mental health difficulties, and then to either not let them join that team or to give them some specific intervention to improve their psychological health. And lots of different ways to do this has been tried. You tried using interviews with healthcare practitioners to mental health professionals, or using psychometric scales, some of them with lie detection sort of subscales in them. But overall, this has not been found to be useful at all. Now, we know the grandmother test is good. I'm not sure if you've heard of the grandmother test, but what the grandmother test is that if you've got someone who's about to go and do a really tough role, and they don't get on with their colleagues and they don't get on with their supervisor, they've had mental health difficulties just recently, they're not getting on with their partner, their children are sick and they've got health concerns, your grandmother could tell you that person's going to have problems. You don't need a psychological test or a psychiatrist to tell you that. Unfortunately, your grandmother would also tell you a lot of other things which we know are not true. So it's difficult to work out when your grandmother's right and when she's wrong. Now, I'm not sure if any of you recognize this person. You probably should do, because this is General Marshall, who was Chief of Staff of the US Army at the end of the Second World War. And the reason I put his picture up is to remind me to tell you about General Marshall's study on psychological health screening. Now, he didn't intend to do a study on psychological health screening. He was a combat officer. But you may or may not know, but in 1939, if you wanted to join the US Army, you had to see a psychiatrist or psychologist who determined whether you were tough enough to join, whether you had true grit, or whether you were made of the right stuff. And if you didn't have, you weren't tough enough, then you weren't allowed to join up. And by 1943, the US Army had ran out of people. And so General Marshall had overturned this policy of screening people. And all those individuals who were deemed to be too weak or unable to cope with combat duties were allowed to come back in. In fact, they were made to come back in. And therefore, after 1943, they went to D-Day, they went to the Pacific, they did lots of hard fighting. And the outcome of the people who came in was that 80% of them, 80% of them, went on and had a perfectly good war. So the screening was wrong 4 times in 5, which is a bit of a rubbish screening. Now, what we did in the UK is we, just like your good selves, sent a lot of troops to Iraq in 2003 to fight our enemies. But before that, we had collected data in 2002 of about 3,000 British military personnel. So we had this data sitting there, which we could use to try and work out who might develop mental health problems when they went to war. And so we let about 1,600 of them went to war, and then we followed them up a year later. Sorry. What we found overall was that using really good measures and using high thresholds, so we weren't just detecting kind of distressed people, that our data showed that we were wrong 4 times in 5. It was no different to how it was in the Second World War with the US Army. That although screening for psychological vulnerability is very seductive, actually we don't know how to do that. And the problem is with that as well, is that you end up excluding people who actually could have done the job perfectly well, but your screening suggested wrongly that they couldn't. So another way that you can use screening in an organization is to look at people who have either come back from deployment or they've just been through a really tough time. And certainly in the UK, and I'm sure you are in the US, we're thinking about how this might be used to try and protect the mental health of healthcare workers who are currently, working incredibly hard on the COVID-19 response. So within an organization, what we know is that screening aims to try and detect people who have got problems and then get them filtered through to get mental health care. So the US military has been screening people like this, troops coming back from deployment, as have the Canadians, the Australians, the Netherlands, and lots of other forces. They routinely give people screening questionnaires and see a mental health professional soon after they come back, and then again about 3 to 6 months later. And for the first time in 2009, the US Army looked at their screening program, and they published the paper in JAMA, which, as you probably know, is a very good journal again. And it had kind of a rather worrying finding. What it found was that people who had been screened and advised to get help actually appeared to do much less well than people who were advised to get help but then ignored the advice. So the screening appeared to be potentially causing damage, which was clearly something they didn't want to happen. Now, what they came out of that is they wanted to do a trial of screening to make sure that it really was helping. But in the US, it was very difficult for you to do that because Congress wouldn't allow the US Army to stop screening people. So you couldn't get a control group. Now, that worked very well for us because in the UK, we had a new government in 2010 who were very interested in mental health screening. And the US military kindly gave us $3 million of your dollars to run a randomized controlled trial of post-deployment screening in our troops. So we screened 9,000 troops who came back from Afghanistan. We used computer-based screening, and we gave the screening group had tailored feedback. So depending on their scores, they were advised to get help and told where to get help from. And the control group didn't get any feedback at all. They just filled in the questionnaires. We followed them up after the screening for about 15 months. And we were primarily looking at, did the screening improve the mental health of the people who used it compared to the control group? And the second thing we're looking for is, did it help with help seeking? So this was published in the Lancet, and what you can see slightly here, because I agree the graphs are rather small, is there's two groups here. One is the screened group, which is like the blue color, and the control group is the other color. And you can see these are different measures. So there's traumatic stress, there's depression and anxiety, any mental health problems, alcohol misuse, and overall well-being. And the important thing here is that 15 months after the screening program, there was no difference between the people who had screening and who didn't. So a good randomized controlled trial of screening showed that it didn't make any difference in people's mental health. And importantly, also, it didn't seem to change their likelihood of seeking any help. So this is health visits, medical service use, welfare use, mental health use, antidepressant use, and sleeping pill use. So this $3 million, 3-year trial, 9,000 troops, and the screening didn't make any difference. And we know that what happens in an organization is that although screening is really well aimed, it's really hoping to help people, that people just don't tell the truth. They're very worried about what might happen with their information. And even when you try and reassure them that actually no bad thing will happen, that their career will be protected and they'll be helped, they don't believe it. And we've done some other studies looking at the impact of anonymity on questionnaires. And we find that where you make questionnaires completely anonymous, so people can't be found, they're much more likely to report symptoms than if you make them identifiable, but then promise people that you won't actually try and find out who they are. So within an organizational setting, screening, however well-intentioned, is very unlikely to work. That's not the same as doing it in the community, where actually people aren't worried about their career or their reputation at work, but certainly within an organization, people are very worried, and screening within organizations, unfortunately, doesn't help. So what does help? Well, one of the things that we know makes a real important difference is about the use of peers within the workplace. And we know that whilst people aren't always very content in talking to mental health professionals, actually many of us spend a long time talking to our colleagues. And the good news is that peers are available everywhere. They don't have to be flown in, they're not specialists. And because they're non-medical, they may well be seen as less stigmatizing. So in 2012, we published a paper looking about, it's a Delphi study. And a Delphi study is where you ask lots of experts to come up with a consensus about what peer support in this case should be about. And this is refined over a period of time through multiple surveys. And the consensus statement on what peer support should do in high-risk organizations is those 4 things. So a peer should provide an empathic listening ear. They should provide low-level psychological interventions. And by that, people meant problem solving or encouraging people to go and seek help. They should identify people who might be at risk to themselves or others. Again, within a healthcare context, that's important because of the sort of care given to patients. And also a peer supporter should be able to facilitate people to get professional help as and when they need it. So within the British military in the late 1990s, we developed a peer support program called TRIM, which stands for Trauma Risk Management. And Although it was set up in the Royal Marines in the late 1990s, it's now used across the military. It's also used by our diplomatic service, by lots of media organizations, lots of emergency services, numerous healthcare services as well, and lots of other companies who routinely expose personnel to challenging situations. It doesn't involve using mental health professionals. It's much more about human resources or people. And it's not a cure. It doesn't aim to prevent people from becoming unwell, because we don't yet know scientifically how to do that. But what it aims to do is to identify people who are at increased risk of becoming unwell, to support them as best as we can in the workplace and to monitor them. And then if they don't do well, then to make sure they get through to professional help. This is actually comes from my doctorate I did a number of years ago, and we asked military personnel who came back from deployment. We said, who did you speak to about your experiences? Perhaps it won't surprise you to know that 97% said, I spoke to people who were just like me, who went on the same deployment, had the same experiences and spoke the same language. Only 8% ended up speaking to medical or welfare services. Now, we know that this is very strong evidence, and there's plenty of other evidence similar, which tells us that people prefer to speak to people like them who speak the same language and who, at least initially, don't have a mental health or even physical health background. What the TRIM training does is take people who are enthusiastic volunteers, who might be healthcare professionals, they might be train drivers, they might be journalists, they might be military personnel, and we train them over 2 days how to use a structured checklist to be able to have a structured conversation with their colleagues to identify who might have difficulties and who might not. This is not aiming to be therapy. This is aiming to actively monitor people who have been exposed to trauma to see whether they might have some difficulties. And this is the TRIM risk factor checklist. I won't run through them all, but this is if you were to do a scientific literature review to look at what predicts poor outcome after trauma, you would find that all of these risk factors are very much within those predictors of poor outcome. And these are also questions that are quite capable of being asked by peer supporters and don't need to have a mental health professional to ask those questions in the first case. What peer practitioners are not, they're not counsellors, they're not therapists, they don't go around giving people a hug, they don't use scented candles or joss sticks or anything like that. This is not about what we would call a pink and fluffy approach to mental health. This is about a colleague who's a bit like you, who's had specific training, being able to sit down with you a few days after an event, and again, importantly, a month later, they do it at least twice, to have a structured chat, to find out how you're doing. And if initially you're not doing okay, you're quite distressed, then what happens is we try and make sure that the team is as supportive as we can be, and that people aren't put through a lot of pressure or stress for a bit of time as they recover. When we go back and we check again a month later, if people are still distressed, then at that point we get people referred through to a proper healthcare assessment to make sure that if they have a need for treatment, that need is met. We've now published 13 academic papers on TRIM. This is not penicillin for trauma, but when you look at the data, put it all together, it is a credible and well received intervention that's pretty effective within organizations at monitoring people and encouraging them to seek help. And importantly, doesn't do any harm, which might seem a strange thing to say, but that's an important thing to remember. And overall, all the different papers that we have done have been in the military, in police, in diplomats, in media professionals, and we're pretty confident that actually this as a system translates really well to any organization that has a reasonable degree of structure to it. And importantly, where there are line managers and supervisors that are able to modify people's day-to-day jobs and to support them. And then coming on to actually where you do have people who unfortunately, even with the best support, go on to need healthcare, it's important that we treat people using evidence-based approaches. And certainly there are plenty of guidelines in the US, as there are in the UK and also in Australia, which really have spent a lot of time getting experts together to try and condense down the treatment papers that are out there to try and tell us what really works. And I think what those papers and what those guidelines say together is treatment definitely makes a difference for a large number of people, but we've got to make sure that it's delivered by trained and experienced mental health professionals. We know that one of the early interventions, which was called psychological debriefing, doesn't work. And I'm not sure if you can read the slide from here. It's two cowboys who say hard to tell from here, could be buzzards, could be grief counselors. Now, I'm not giving grief counselors a hard time because they have a really important role. But what we know in the aftermath of most traumas is that there's often a call for mental health professionals to come in and make things better. And actually, when you look at the evidence about psychological debriefing, it's pretty clear that, first of all, it doesn't work. It doesn't make people better. People who don't get debriefed do just as well. And actually, when you look at the data in more detail, the evidence appears to be that actually people who get psychological debriefing actually do worse. And so from an organizational point of view, if you're not well prepared, you may think the best thing for you to do is to phone your counseling company and get them in to help. Actually, that's not what you should do. After a traumatic event, this is a time that leaders and comrades need to stick together and to provide good support internally, and to do what's called active monitoring, to keep an eye on people, and then check in with them after a month to see how they're doing when you've supported them in the month beforehand. And then what NICE say is, that's our National Institute for Health and Care Excellence, is to give them focused treatments that we know make a difference. And cognitive behavioral therapy and EMDR, which was devised in the States, eye movement desensitization and reprocessing. These are both talking therapies. They can be effective for a large proportion of people who become traumatized. There are lots of interesting ways to do treatment. That you can have intensive trauma-focused cognitive behavioral therapy, not delivered over 3 months, but delivered intensively with 16 hours over 1 week. The evidence is that for a lot of people, that gets just as good an outcome as delivering therapy over many, many weeks. So wouldn't it be amazing to take a slightly damaged and broken individual who's traumatized, put them through a week's trauma treatment that's intensive, and at the end of it, they're ready for a graded return to work? That would be a really positive thing. And indeed, that goes on in areas of the UK who've adopted this. We know that also remote delivered trauma-focused therapies are effective, which is lucky in the current climate that we live in. We also know that we can train up paraprofessionals. We can train up non-experts in delivering trauma treatment. We did this in West Africa after the Ebola crisis with workers in Sierra Leone. And actually, by training them up, they were able to deliver pretty reasonable trauma-focused treatment to people with relatively little training. There's also some new ways using 3D and using MDMA-assisted psychotherapy to make a difference. We also know that working with someone's partner makes a difference. And the key thing is to get early treatment before people lose their job and their relationship and their self-esteem. That's what's really important. We do, however, have to be careful of snake oil salesmen. There are plenty of people out there who will try and sell you a quick trauma cure. Many of them, these are based upon neuro-linguistic programming. And the key thing is that when you ask someone who has a snake oil intervention, you say, well, what's the evidence? Usually what they'll tell you is they have plenty of testimonials and they don't have good papers published in scientific journals, which absolutely we need to start with, because you should start with the best evidence-based therapies. And if they don't work, by all means, one may drift into more esoteric things. So in summary, we know that most people exposed to traumatic events will cope, and so they're most likely to get distressed, and then a few of those will become ill. And unfortunately, those who do become ill are unlikely to seek help. There are definitely evidence-based ways to prevent, detect, and treat trauma-related problems. And overall, the best initial interventions come from within the team. So people should have improved support and reduced pressure for a short period of time, and that will maximize their chance of recovery. We know that actually post-incident support isn't when someone's flown in who's an expert. It comes from within the organizations. And it's a bit of a cheesy phrase, but I strongly believe that mostly resilience in organizations doesn't lie within people, but it lies in the bonds between them. And so what we should do is to try and improve those bonds and give colleagues and particularly supervisors the skills to be able to properly support their staff, and that will lead to benefits in terms of their own mental health. So that's me. I'll happily take any questions. Thank you.
Thank you so much, Neil. That was extremely helpful. And it's a great overview of the evidence, you know, and many of the research studies that you've done as well. So thank you for that concise presentation. Was so clear. We have a number of questions, and people are asking about critical incident stress debriefing. And they're asking, is this not recommended? So I want you to please comment on that.
Yeah, so critical incident stress debriefing started in the 1980s, and this was actually in the States by a firefighter called Jeffrey Mitchell, who quite rightly spotted that many of his colleagues were having trouble after attending nasty incidents. And the thought at that time was that what was happening is that they weren't able to express their emotional responses in a cathartic way in the immediate aftermath of a trauma. And so what he did is devise a 7-stage process to try and encourage people to get out all those nasty emotions early on, with the aim of it preventing people going on to develop post-traumatic stress disorder. When it was subject to scientific scrutiny, and it's been looked at in randomized controlled trials a number of times, it was not found overall to be effective. And worryingly, the people in the debrief group, particularly the ones who were followed up for years later, did less well than the people who were in the control group. So the national guidance across the world doesn't recommend debriefing. The US International Traumatic Stress Society guidance doesn't recommend it, nor does the UK or the Australian ones. And the UK and the Australian ones specifically recommend against it because of the risk of harm. So the idea of flying in kind of mental health professionals undermines people's own level of resilience and their self-coping. And of course, mental health professionals are usually very good at dealing with patients, people who are ill. But in the first few weeks after a trauma, people who are distressed are often not ill. They are experiencing normal levels of distress. And the response to that they need is good support, a reduction in pressure, and some time to activate their own coping mechanisms. And the danger is that what debriefing does is to undermine those normal coping processes. And it doesn't lead to people having better psychological health. And on balance, it's likely to lead to them having worse outcomes.
That is very important information. And a number of our listeners actually asked about that. So thank you for that. Several other questions here. One was responding to the stigma associated with asking for help, Neil. And I know you commented that this is declining in the military, but I think this is very prevalent in the culture of medicine here in the United States. So I'm curious how you managed to actually accomplish the decline in stigma and encourage people to reach out for help.
Yeah, it's a very good question. And the first thing to say is, although it is declining, it absolutely has not gone away. So when we first started measuring it in British military personnel in 2009, we used a 13-item stigma scale, and we found that over 80% of people reported one or more stigma items strongly. So that was 2009. The last time we looked was about 2 years ago, and we found that it was about 55% report one or more stigma items strongly. So that is a very positive decline, but it still is a long way to go. In our national studies as well, we find that help seeking in 2007, 1 in 4 people in the UK who had mental health problems are seeking help. And by 2014, that had gone up to 1 in 3. So I think the direction of travel in the general population and also within the military is positive, but there's a long way to go. I would absolutely agree, in healthcare settings, there is a very strong preference for not seeking help and for just carrying on, and somehow people thinking that they're invulnerable because they are a healthcare professional. I think what we found is that there is no one magic bullet within the military to reduce stigma. But what has happened over a period of time is that multiple programs, including TRIM, but many other programs have been put in place. And because of the conflicts in Afghanistan and Iraq, the same as for your troops, there has been a great emphasis on improving the mental health of troops. And I think put all together, all the programs and the senior management and leadership emphasis on mental health has added together to make it slightly more easier for people to seek help. I think within healthcare settings, very similar to the military, what we find is that people's preference is to try and solve problems themselves and not to seek help. And of course, what we could say is, well, that's wrong. They should go and get help early on. But actually, I think the evidence is pointing towards we should try and give people who want to seek help the tools to do so. And actually, the US Veterans Association, the VA, has come up with a very nice app, which is called PTSD Coach. And again, this is not an intensive treatment facility, but it gives someone who wants to help themselves, who may not have formal PTSD, but they've got some difficulties. It gives them a range of different tools that they can use that might make a positive difference. And I think also within healthcare settings, something similar could be applied, where we actually try to help healthcare professionals who recognize they've got a difficulty to try and seek help. One of the very interesting, again, importantly comes from the States, interesting approaches to encouraging people to get help comes from looking at the family dynamic. So we know that although people may appear to be okay at work when they go to a hospital or clinic, actually, if you ask their spouse or family, they would tell you that the individual is having a lot of problems, although they won't admit it. And so there is an intervention called CRAFT, which is Community Reinforcement and Family Training. And what CRAFT does is it tries to help the spouse of someone who's got mental health difficulties both recognize that the mental health difficulties in their spouse are causing problems for the family, but importantly gives them the skills to be able to nudge their loved one towards getting help. So the CRAFT therapy is directed at the family member the loved one who's got the mental health problems, and it gives them the knowledge and skills to work out when the right time is to have a conversation with their loved one, and the skills to be able to nudge them towards getting help. And actually, although we're early days in that, I think it provides a very useful potential tool for trying to help people who won't get help ordinarily from to actually go and get the help they need. So I think you're quite right, within healthcare settings, health professionals don't tend to get help. But often I think people around them, their colleagues and their managers, and importantly their family, would have the ability, if we could help them, to be able to nudge someone towards getting help when they need it. But we should also work on providing them with self-help tools, because that's their preference in most cases to start off with.
That's so interesting, and what a terrific bunch of resources. And one of our listeners has also said that the VA here has put out another free app that's specifically designed for the COVID-19 pandemic called COVID Coach. We'll look into that a little bit and try to send a link, set a link up on our website if that's open to the public. You mentioned about leadership and the role of leadership, Neil, in terms of helping significantly normalize, validate the need for accessing help as one potential contributor to the decline in stigma in the military. And we have had many reflecting here about what they feel really is leadership indifference, lack of attention to the need for personal protective equipment, for adequate staffing, for adequate resources. And I know you're interested in moral injury, and I think this is going to be a very significant source of injury to many people who are taking care of patients on the front lines here in the pandemic. I wonder if you can just comment on that. It's really a form of leadership abandonment, if you will, as perceived by those who express that sense. So can you talk about moral injury and what to do about this? Do you think it's going to affect how people function later on? Will it affect their own personal outcomes, their health outcomes, the attrition that might ensue? What are your thoughts?
Yeah, so we've looked at moral injury, not just in the military, but also in other groups of people who are routinely exposed to potentially morally injurious events. And so actually that there are a wide range of professions who come across these situations regularly, healthcare professionals being one, but also social workers, and actually media professionals who have to make a decision between getting the story or helping the person out who's in trouble. What we know about moral injury is that it occurs in a situation when a situation strongly violates or clashes with your moral or ethical code. It can result both, from acts of commission, so you may do things that later you wish you never did, acts of omission, where you really think you should have done something but you didn't do anything, and also acts of betrayal, where you feel that people in trusted authority positions didn't do the right thing by you. And I think in the current outbreak, there is the potential for people to feel that their managers and that the nation isn't providing the right equipment, isn't providing the right training, and they're asking me to do tasks that I'm absolutely unprepared and ill-experienced to do. So you put them all together, I think the potential for moral injury at the moment is really quite high. Most healthcare professionals, I would hope all of them, want to deliver the very highest standard of care. And sometimes when there are too many patients and there's not enough staff and not enough equipment, that may just not be possible. And that has the potential to really impact on healthcare professionals and mental health. It's important to say that moral injury itself is not an illness, but it definitely makes you vulnerable, and we know, to post-traumatic stress disorder, to depression, and to substance misuse, and also suicidality later on. And I think the key point in the current crisis is that actually healthcare workers need to have a frank and open discussion before they start work. I mean, we're probably too late now, about actually the difficulties and challenges they're going to face, that it just will not be possible at all times to deliver the standard of care that you might want to. We're actually very supportive, and we mentioned it in our British Medical Journal paper, of Schwartz rounds as a really useful way of discussing these morally challenging situations in a open and frank manner. Because what we find with moral injury is, because it's associated with shame and guilt, that people often don't want to talk about it. And they might instead talk about trauma, the people dying and how unpleasant it was, and they kind of gloss over the shame and the guilt. And what happens then is, if they go and get treatment, because the shame and the guilt are not addressed, and people end up thinking that if people knew what I was really like, they would know that I was a monster, that it's all my fault that this happened. So they don't talk about it. And then treatment for PTSD that they might get doesn't really work, because they haven't really got to the heart of what the problems are. So we think it's really important that healthcare services recognise this as a potential problem. They both speak about it openly and try and get people to have a narrative that doesn't end up blaming their boss or themselves or somebody else, but as much as you can ends up blaming the situation, because the situation, as lots of people are saying, is unprecedented. And that where people do get sent forward to get professional therapeutic care for mental health problems, therapists should absolutely be clear that they should be asking about shame and guilt and probing for it gently to make sure that it's not missed, because actually it's likely to be a real issue for a number of people.
And it's an important distinction that you make, actually, between PTSD and actual clinical symptoms, and this sense of shame and guilt due to, whatever presumed misbehavior or inability to behave in ways consonant with your moral values has created. Very important distinction, I think. I think we have run out of time. We have some excellent questions here on the panel, and I'm sorry that we don't have more time to address them. I do want to point out that we will be posting Professor Greenberg's article, one of them, and there are many articles we may actually be able to post later on as well that refer to moral injury. In particular, there was an excellent article in the BMJ that was just published, and there's also a very, very good article on the impact of quarantine and how to reduce its impact. So just a wealth of information from your group, Neil. We really appreciate it, and we appreciate your taking the time to share your wisdom and your experience and your expertise with us here today. So many thanks to you, and I'm going to turn the program back over to Stephanie.
Thanks, Beth, and thank you so much, Professor Greenberg. We really hope everyone enjoyed this wonderful presentation today, and we hope you'll join us again. We have a great slate of speakers over the next few weeks, including the return of fan favorites, Dr. Patricia Watson and Dr. Richard Westphal, this time talking about supporting patients and families in crisis. Following that webinar, we'll have Dr. Tony Back from Vital Talk sharing with us on communication in the age of COVID. And then last but not least, we are so excited to share news of our 2020 Compassion in Action Conference, which will be offered as a virtual event this year, beginning on June 16th. And we'll have an outstanding series over 4 months of workshops, panels, and speakers. We hope some of you will join us. There's more information online. Until then, we know you're busy. Thank you so much for joining us today. We would very much appreciate your taking a moment to complete our quick survey. And we hope we'll see you back next week for our session with Dr. Watson and Dr. Westphal. Take good care, everyone, and thank you.